Hi, my name is Jessica Jova, and this is multiple cancer diagnosis equals multiple modality treatments. Welcome to Pepper's Village. This is Pepper, miniature schnauzer, born in 2007. I met him in 2017, a long time before COVID, in an exam room, face-to-face with his owner, no mask, like regular people. Pepper had been sent to see us in oncology at Veterinary Specialty Hospital, the Carolinas, Durham, now Blue Pearl Hospital, after initially seeing his primary veterinarian for inappropriate urination and a significant increase in the amount of water he was drinking. Pepper's primary vet performed a thorough physical exam, which did reveal a right-sided anal sac mass about 2 centimeters in diameter, and went ahead and submitted a CBC and a chemistry panel as well. The CBC was mostly unremarkable. The chemistry panel did show a mildly increased total calcium. So Pepper returned to his primary vet 2 days later for additional diagnostics, including a fine needle aspirate of the anal sac mass, 3-view thoracic radiographs, and an abdominal ultrasound. Cytology on the mass returned a diagnosis of carcinoma, and the thoracic radiographs for a metastasis check showed a possible nodule versus superimposition of structures in the right middle lung lobe. The abdominal ultrasound showed an enlarged right sacral lymph node, polypoid cystitis, and cystic calculi, along with bilateral degenerative nephropathy. So after that workup, Pepper came to see us in oncology, and we recommended a CT of the pelvis for the primary tumor and the thorax to further evaluate the possible lung nodule. The results of the CT were that the right anal sac mass, consistent with an apocrine gland anal sac adenocarcinoma, and medial sacral lymphadenopathy, likely metastatic lesions. Also, it did see cystic calculus and multiple polypoid urinary bladder lesions, most likely polypoid cystitis. There was no evidence of metastasis in the thorax, so that was good. An ultrasound-guided fine needle aspirate of the median sacral lymph node was obtained and submitted for cytology. The interpretation of the sample was reactive lymphoid hyperplasia with occasional mast cells and evidence of chronic or recent hemorrhage. Not exactly what we were expecting. So Pepper's owner was offered and chose surgery as first-line treatment for his carcinoma. In addition to the primary mass removal, Pepper had the enlarged lymph node removed, a cystotomy for stones, and those bladder polyps were biopsied, as well as the bladder mucosa was cultured. So the morning of his surgery, Pepper's ionized calcium was 1.56 with a reference range of 1.13 to 1.42. The morning of the day after surgery, it was 1.54. By lunchtime that day, had started to go down and was 1.45. And just 48 hours after that, it was 1.28, back to within the normal range. His levels were checked again 4 days later and remained stable at 1.32. He felt great at home, no problems at that point. So Pepper's biopsy results came back. As expected, the bladder samples were polypoid cystitis with irritation by uroliths as a possible cause, no evidence of active infection or malignancy. And the stone analysis showed us Pepper's stones were calcium oxalate, which we knew could happen secondary to the high blood calcium as a result of his anal sac carcinoma. The removed right anal sac tumor was confirmed to be apocrine gland anal sac adenocarcinoma. Additionally, however, the lymph node was metastatic, which we had suspected based on its appearance, but obviously the cytology had read differently. And quoting from the biopsy, there was no recognizable normal lymph node architecture, and the lymph node was completely effaced by a neoplasm. So these findings, as I said, agreed with the radiologist's impression of the lymph node on imaging from the ultrasound and the CT. It was interesting that we got different results on the cytology, but it is a good reminder that the cytology results are for the individual cells that are presented to the pathologist, not for the entirety of the lesion from which the sample was obtained. I pressed pause, I don't know if it worked. So after Pepper continued to feel well after surgery, his PUPD resolved. He came back to see oncology 3 weeks after his surgery. The clinician recommended systemic chemotherapy treatment for the carcinoma in an attempt to counteract its tendency to spread, which Peppers had already done, as we saw in the lymph node. The recommended protocol is IV carboplatin every 3 weeks, ideally for 4 to 6 doses. Additionally, restaging with an abdominal ultrasound and thoracic radiographs is recommended before the last scheduled treatment or at any time if there was concern for disease progression. In Pepper's case, we'd be especially concerned with an increase in his thirst, change in his urinary habits without evidence of infection, obviously an elevation in his ionized calcium, straining to defecate, a change in stool shape or size, blood in the stool, or evidence of abnormalities on a rectal examination. Any of those things would prompt restaging. So Pepper received his first dose of carboplatin at the 10 mg per kg dose strength on December 5th, 2017, and was sent home with prophylactic antibiotics, specifically Clavamox, to be started 5 days later. He was also sent home with Serenia and metronidazole to use as needed. So about carboplatin, beyond the easily observable side effects, it can cause bone marrow suppression, leading to a low white blood cell count or low platelet count. So in order to evaluate patients for these side effects, CBCs run 7 and 14 days post-treatment. When bone marrow suppression is noted on lab work, it's usually self-limiting, with most patients recovering back to normal levels about 3 weeks after administration. Patients who become severely neutropenic, less than 1,000 neutrophils, will need to be on antibiotics until their counts come back up. Thrombocytopenia generally resolves with time as well. If platelet counts get exceptionally low, patients are at risk for bleeding and will recommend they have activity modifications to prevent injury. So how did Pepper do with his carbo? He was a good boy for the administration, and he did not experience any troubles with GI side effects. He ate great, no worries there. CBCs 1 and 2 weeks post-chemo administration, done by his primary vet, showed a moderate neutropenia, but no troubles or changes needed. He came back to VSH 3 weeks after the first treatment and was neutropenic at 1,240 neutrophils. So he was prescribed additional antibiotics, advised to return in 1 week. So 4 weeks after carbo administration number 1, he was advised to come back. As you can see, carboplatin can have a unique nadir pattern, with the first nadir being 10 days post-treatment and a second around 21 days post-treatment, and that's what we saw in Pepper. So for the second dose of carboplatin, Pepper was given a 20% dose reduction, receiving 8 milligrams per kilogram instead of 10 milligrams per kilogram. Obviously, this was done in an effort to prevent the low white blood cell count seen 3 weeks after the first dose, so that the advisable frequency of chemo administration every 3 weeks could be maintained. 21 days later, Pepper shows up for his next chemotherapy appointment. We run a CBC, and his neutrophil count was exactly the same as the first time, 1,240 neutrophils, well below the safe cutoff treatment of 2,000. So we delayed treatment for another week. By the time Pepper comes back and his neutrophil count was high enough for chemotherapy administration this time, we're 2 weeks behind ideal schedule. So we went ahead and restaged him in advance, a little advance of our plan. Thoracic radiographs and abdominal ultrasound and ionized calcium were all normal, so that was great. We did, however, see evidence again of new bladder stones. So while these initially were suspected to be due to the elevated blood calcium, in the absence of that condition this time around, the focus shifted to their formation being an unrelated problem. All of you know one to which miniature schnauzers can be predisposed. So on the advice of the internal medicine department, Pepper was placed onto potassium citrate tablets and cranberry extract for bladder stone management. He did receive his 3rd and 4th dose of carboplatin at the 8 mg per kg dose with a 4-week dosing interval. On February 27th, he got his 4th dose of carboplatin. And at this point, he had received care from medical oncology, surgery, radiology, and internal medicine, and was released from active treatment to a monitoring schedule. So he was basically in remission from February 2018 to June 2019. He had periodic restaging, continued to feel well, and everything looked really good. However, in December 2019, Pepper began to exhibit signs of polyuria polydipsia again and was evaluated and treated by his primary veterinarian for a urinary tract infection. Unfortunately, on physical exam, he was noted to have a small left-sided anal mass, and his blood work once again indicated an elevated total calcium. After treatment for the UTI, his PUPD persisted, and he was referred back to come see us in oncology. He was restaged with blood work, which had a total ionized calcium at 1.74. Thoracic radiographs did not show evidence of metastasis, and an abdominal ultrasound did show bilateral medial iliac lymphadenopathy, and once again, bladder stones and polyps. Pepper's owners at this point opted to move forward again with surgery without further imaging, no CT for staging or anything, no cytology of the primary mass or the enlarged lymph nodes. They just went straight to surgery. So the anal mass was excised, both enlarged lymph nodes were removed, and he again had a cystotomy. However, on intubation, an oral mass was noted. A phone call was immediately made to the owner, who opted to continue with the original surgical plan, and if everything was going okay, add a biopsy of the oral mass. The anal mass and lymph node histopathology returned as carcinoma as expected, and the oral mass returned as malignant melanoma. Once again, 4 days after surgery, Pepper's ionized calcium had normalized and he was feeling well. So now we have to talk about treatment options for the oral malignant melanoma. This disease has a high metastatic potential, so treatment is indicated at the local and systemic level. Local treatment options are generally surgery and/or radiation therapy, and systemic treatment is with carboplatin, IV chemotherapy, palladia, metronomic cyclophosphamide, any of those, and often the oral melanoma vaccine. So 2 weeks after the oral biopsy, Pepper returned to oncology to discuss those treatment options. At that time, his melanoma had already significantly increased in size and was interfering with his eating. So obviously with that rapid growth, this was concerning and very suggestive of an aggressive tumor. At this point, it was likely that the melanoma was going to cause quality of life concerns before his anal sac tumor was. For local treatment, Pepper's owners chose radiation therapy over a mandibulectomy, to be followed by the melanoma vaccine, and then carboplatin chemotherapy, which would have the benefit of treating the carcinoma as well. So Pepper was scheduled for a CT for radiation therapy positioning and staging. And at that point, the CT measurements of the rostral mandibular mass were 3 by 3.4 by 3.5 centimeters. And there was bilateral asymmetrical mandibular lymphadenopathy as well. Aspirates were obtained and submitted for cytology of both lymph nodes, and both returned as reactive, no tumor cells seen. So Pepper was signed up for RT. This is a picture of actually his tumor at the time of the CT, right before radiation positioning. Radiation therapy was delivered for 6 total treatments, twice a week for 3 weeks. Melanoma is treated with fewer doses of radiation, but at a higher dose per treatment than most other solid tumors. They were initially thought to be minimally responsive to radiation therapy, but a hypofractionated treatment protocol can be very effective. As seen in Pepper, a recheck just 7 days after completing radiation therapy already showed significant reduction in the size of the tumor. There was no bleeding, and he had regained excellent function in his mouth in terms of eating and drinking normally. These are some pictures of the radiation positioning CT showing the bag, bite block, and mask used to maintain repeatable positioning of the patient. So after his radiation therapy, Pepper received the Oncept canine melanoma vaccine. So historically, vaccines stimulated immune response directed at foreign proteins. So tyrosinase is a protein present on all cells containing melanin, both melanoma tumor cells and normal cells. Therefore, it's not normally attacked by the immune system. Oncept is produced by using a human gene for tyrosinase, which is different enough from canine tyrosinase to generate an immune response in canines, but similar enough that that immune response is directed to the tyrosinase found on the canine melanoma cells. That particular protein is overexpressed on malignant cells as compared to normal melanocytes, allowing the immune response to be relatively tumor specific. So for the vaccine, a volume of 0.4 mils is administered using the VetJet transdermal vaccination system over the muscle of the medial thigh, just caudal to the femur. It's administered every 2 weeks for the first 4 doses, and then we give a booster every 6 months thereafter. It is recommended to restage at the completion of that initial series at the 4th treatment. And for Pepper, those thoracic radiographs at that 4th vaccine did show possible evidence of very early pulmonary metastasis. So after his vaccines were completed, there was such a significant tumor regression that due to the location of his tumor, Pepper was left with a large number of very loose teeth and concern for infection being harbored in his mouth. So he was referred to dentistry. Dental radiographs were taken, and it was determined that he needed 12 extractions and lengthy courses of clavamox and metronidazole in an attempt to clear and prevent infection in his oral cavity after those extractions. Additionally, there was some abnormal tissue noted adjacent to his 1st and 2nd maxillary incisors, and so a biopsy was submitted for histopathology. Fortunately, the biopsy did not show any evidence of neoplasia. So after Pepper healed from his extractions, he returned to medical oncology with a plan to start IV chemotherapy, the carboplatin again. We completed his restaging for the carcinoma at that point, and on physical exam, there was, quote, minimal irregularity and pigmentation of the rostral mandible, which was pretty amazing considering where we started, indicating a continued excellent local response to the radiation therapy. However, the ultrasound unfortunately showed multiple new small intestinal masses, which had not been there before, and no lymph node enlargement was noted. So the lack of lymph node enlargement suggested that the new masses were less likely to be the metastatic carcinoma, because we would expect those lymph nodes to be much bigger if that was the case. It was also a very unlikely manifestation of the melanoma. So the suspicion was that Pepper had a new primary neoplasia. So carboplatin was not administered that day while we waited for cytology results to come back. Ultrasound-guided aspirates were taken of several of the intestinal masses and submitted for cytology. However, the cytology ultimately did return with a diagnosis of metastatic melanoma. So Pepper right away received a 5th dose of carboplatin at the 8 milligram per kilogram dose because we knew that was all he could tolerate. Chemistry panel at this visit showed his ionized calcium remained normal. On physical exam, he did have at least 2 new pigmented dermal masses suspected to be melanomas as well. His owner reported that he continued to have an excellent quality of life, good appetite, good energy level, no PUPD, no trouble defecating, no changes in his breathing. If you go back and read his discharges, the last sentence of the owner updated history from that visit was, he seems happy. So Pepper was given his carboplatin, sent home with prophylactic antibiotics, antiemetics to use if needed, and advised to have a recheck CBC with his primary vet in 2 weeks. and scheduled to return to oncology to see if he was eligible for a 6th dose of carboplatin at the 3-week time frame in an effort to stay on the preferred dosing schedule. We were being optimistic that we could treat him that quickly. So by this point, Pepper had at least 38 visits to VSH from 2017 to 2020. He had seen medical oncology 19 times, radiation oncology 10 times, surgery service 7 times, had been to see dentistry twice, and had extensive consultations with at least 3 services, internal medicine 3 times, and had upwards of 20 radiology reports and 17 pathology reports written during that time frame. On June 27th, 2020, Pepper died at home in his sleep overnight and was brought in for private cremation the next morning. For 31 months, through 2 metastatic cancerous diagnoses, with the help of a whole village of services, Pepper seemed happy. That's Pepper.